If you've been dealing with heel pain for months, you've tried orthotics, stretching, maybe even injections, and nothing is actually fixing it, then there's a key question most clinicians are not asking: is this really plantar fasciitis anymore, or is it nerve-related pain? Today I'm going to explain a highly targeted, evidence-based treatment called ultrasound-guided hydrodissection and why it can be effective in chronic, non-healing heel pain. First, this is critical. This is not a treatment for new heel pain. Acute plantar fasciitis, what we now call plantar fasciopathy, is primarily a load-related degenerative condition. Early stage management should focus on load modification, progressive strengthening, footwear changes, addressing biomechanics. Shockwave therapy, hydrodissection is reserved for a very specific group: chronic heel pain that has failed standard care, where nerve irritation or entrapment is suspected. Problem reframing. In persistent heel pain, the diagnosis often remains plantar fasciitis, but the reality is more complex. Research shows that chronic heel pain can involve medial calcaneal nerve irritation, Baxter's nerve entrapment, first branch of the lateral plantar nerve, peripheral sensitization. Key clinical features that should raise suspicion: burning, tingling, or radiating pain, pain that doesn't follow a classic first step pattern anymore, failure of multiple standard treatments, pain that worsens with prolonged standing rather than just loading. At this point, treating it as a simple plantar fascia problem is often ineffective. What is hydrodissection? Ultrasound-guided hydrodissection is a precision image-guided procedure. The goal is simple: to mechanically separate a nerve from surrounding structures that may be compressing or irritating it without surgery. Under real-time ultrasound, the nerve is identified, a needle is placed adjacent to it, fluid is injected to create a physical plane of separation. Before I carry out this hydrodissection injection, I always perform an ultrasound-guided local anesthetic injection to numb the area first. This is important as the hydrosalpinx can be painful without this. This does three things: releases mechanical entrapment, reduces local inflammation, restores nerve mobility. The solution injected is typically a combination of saline, local anesthetic, corticosteroid, or sometimes dextrose. The key is not the drug, the key is the mechanical decompression. Why ultrasound matters: blind injections in this region are unreliable and can be dangerous. Ultrasound allows direct visualization of the nerve, identification of the surrounding fascia and soft tissue, real-time confirmation of fluid separating tissue planes. This is critical because if you're not around the nerve, you're not treating the problem. It turns a vague injection into a targeted intervention. Who is the right patient? This is where outcomes are determined. The ideal candidate: chronic heel pain, 3-6 months, failed evidence-based conservative care, clinical suspicion of nerve involvement. Often, tenderness is more medial or deeper than classic plantar fascia, may have partial but temporary relief from previous injections. This is not first-line treatment, a shortcut, a replacement for good rehabilitation. It is a next-step intervention in a structured pathway. Evidence and mechanism. Hydrodissection has growing evidence across multiple entrapment neuropathies: carpal tunnel, neuralgia, paresthetica, peripheral nerve adhesions. The mechanism is consistent: mechanical decompression, reduction in intraneural pressure, improved neural gliding. In heel pain specifically, Baxter's nerve entrapment is well documented in chronic cases. While high-level RCTs in plantar heel pain are still limited, the biological plausibility and extrapolated evidence are strong, and clinical outcomes are increasingly reported as favorable in well-selected patients. What patients can expect: procedure performed in the clinic takes approximately 10-15 minutes, local anesthetic first. Laughing gas is also available if patients are particularly nervous. Ultrasound guided throughout aftercare, relative rest for a couple of days initially, icing daily for approximately 5 days, gradual return to loading, often combined with rehab to address underlying mechanics. Response: some patients experience immediate relief from a local anesthetic. The true effect develops over days to weeks, occasionally requires repeat treatment. Risks are low but include Temporary soreness, bruising, there is a very small risk of nerve irritation if done under ultrasound-guided. Big clinical takeaway. If heel pain is not improving, the question is not which treatment haven't we tried yet? The question is, have we got the diagnosis completely right? Because once nerve involvement is present, continuing to treat the plantar fascia alone will often fail. Ultrasound-guided hydrodissection is not for everyone, but in the right patient, it provides a precise, targeted way to address a commonly missed driver of chronic heel pain. If you're a practitioner managing persistent heel pain or a patient who's been through multiple treatments without success, this is an area worth considering, because chronic heel pain is rarely simple, and the solution is often in identifying what's been missed. I am Damien Lafferty, a surgical podiatrist from Sydney. If you found this interesting, you may want to subscribe or watch the next video.